Hi everyone, good morning. So I hope you all are
Good
good.
morning, sir.
Very good morning, Rahul. So how are you all? How was the Diwali? Very good morning, everyone.
Good morning, sir.
Yes, I'm good. I'm good. I'm now perfectly fine. So that's why I thought let's finish the course. We have completed our 6 weeks. Okay, my video is not going, huh? What's the problem? Okay, so guys, let's start. Let's not wait much. So, today is our last class for this batch, the 6 weeks course. That is not exactly, now it's almost 2 months course. We have started in September, I mean, on the August 28th, and today is the October 30th. Due to my health problems, I got COVID in between, and we could not, finish the last class this month. Otherwise, I could have finished it on the first week of October only, but due to the health problems, I could not take. And then, last week I was at my home for Diwali, but no worries. We are finishing it today. So today is our last class, and I'll be taking class on cardiomyopathies. So before going to that cardiomyopathies, I would like to talk to you guys. So that we have launched our second series also. So whoever is interested in the full 1 year master's program, okay, this is a 1 year master's program, and there are 5 series. There are 5 series, okay, not only one series. So there are 5 series, and we have just recently launched the second series, and we are coming up with the ECG course also. So we are thinking to merge both of them. That just, I mean, it's in the process, but today is the last date to register for the series 2. So whoever wants to continue for the series 2 also, and for the master certificate course. See, there are the 5 series in the complete entire 1 year master's course. Okay, so series 1 is completing today. Series 2 is completely based on arrhythmias. That will be starting very soon, next week, and you can be a part of that also. So whoever is attending all 5 series, okay, I mean, you will get the certificates for each series individually. But if you are interested, you can be a part of the master certificate program, and then master certificate you will get after completing all the 5 series. Okay, all the 5 series, and the price for all the 5 series will be 149 only, I mean, individually. Okay, so if you think like a we are going to increase the price at the end or later for the next series or something, for the all 5 series the price will be 149 each only. That we have decided in the starting only, right? So this is like 6 into 5. There will be 30 weeks program. The entire program will be 30 weeks. Okay, and at the end you will get the certificate for the 1 year program. I mean, technically there will be 30 classes entirely, but you will get the certificate for 1 year master's program, because that will be completed in next 1 year. Next 1 year means almost we have completed 2 months, but 10 more months, and we'll be completing by most probably by August 2023 the entire 5 series. Okay, so if you want to be, and the each series will have the specific super specialty programs. Super specialty means it is cardio, but in the cardio also there will be different topics. Like in the first we have just covered basic the basic diseases, and second we are completely focusing on arrhythmias. Then might be we'll be focusing on RHDs, then might be focusing on the pediatric cardiology. So there are multiple things what you have to learn and what you have to understand, because the cardiology is my favorite program and is my kind of passion, and I have done my PhD in cardiology. So I'll be taking you through my experiences, through the real time cases, and through all the series. So if you are interested, you can join us for the next programs also, the cardio series 2 on arrhythmia. Okay, guys. So today is the last class, and I'll be teaching you cardiomyopathies. So in cardiomyopathies, before I start the cardiomyopathies, let me share my screen and let's discuss. Wait a wait a minute. Okay, so that's my slide. Okay, yeah, I hope it is visible to all of you guys.
Yes, sir.
Okay, you can just confirm. Fine. Okay, it is visible. Let me make it full screen. Okay, so today, in the cardiomyopathies, it is a very, very tough topic, guys. Okay, if you think cardiomyopathies are the simplest topics or cardiomyopathies you will understand easily, you even don't know the types of cardiomyopathies. Okay, I'm very sure all of you don't even know the types of cardiomyopathies. I'm very, very sure. Okay, so today we'll be just taking the basics of cardiomyopathies, the general topics in cardiomyopathies, not at all the tough program. Okay, not at all the tough where you cannot understand or it will make tough for you. I'll not make it actually overwhelming for you guys. Okay, it is very, very simple. I'll make it simple for you, and we'll be talking about these very general, in very general, so you can understand all the things, right? One second, guys, I'll just go on my YouTube. Oh, oops. I'm so sorry. I think I was speaking and you guys were not able to listen to me. I was on mute. Oh, you can guys talk to me if, I'm on mute. You can tell me. So what I was telling is cardiomyopathies. I was talking like, cardiomyopathies. If I say that cardiomyopathies are, related to heart failure, then it will not be a wrong statement. But if I say that cardiomyopathies are the heart failure, then it will be definitely a wrong statement, because heart failure is the ultimate, what we say, the prognosis of cardiomyopathies. Okay, there are dilated cardiomyopathies, there are hypertrophic cardiomyopathies, there are restrictive cardiomyopathies, there are arrhythmiogenic cardiomyopathies, there are, other genetic cardiomyopathies. So there are multiple reasons for different cardiomyopathies, and ultimately these things lead to the heart failure and the sudden cardiac death. Okay, so let's go and let's try to understand. If you don't understand, please tell me in between, and we can talk. We can, try to understand it as much as possible. I'll try to make it very simple for you. I did not keep pathogenesis, I did not keep the entire pathophysiology, because each cardiomyopathy has its own pathophysiology, its own management, but I try to get the common things where you can at least understand what could be the diagnosis, what could be the management, what could be the common etiologies, what are the differential etiologies for other things. Okay, so I have taken some of the common diagnosis part, common etiology part, common management part. It is in the first class, so you can understand about the cardiomyopathies. This is just to make you understand about the cardiomyopathies. Okay, so let's start with the definition. Okay, cardiomyopathies definition. So as you can see here, cardiomyopathies are a mixed group of diseases of myocardium. Okay, so just look at the highlighted points. Okay, diseases of myocardium means the cardiac muscle. Okay, it could be defined by structural or functional abnormalities. Structural or functional abnormalities. So you can find the similarity here. What we were teaching and what we were learning and discussing in the heart failure. Similarly, okay, similarly, it has shown here the due to or the defined by structural or functional abnormalities that negatively affect the pump function of heart. Pump function of heart is called as what, guys? What is the pump function of heart? And how and what it actually leads to? Heart failure. Okay, this is heart failure. You guys can talk to me and I'll ask you the questions, so we'll make it interactive. So cardiomyopathies are like a group of diseases, multiple diseases which affect directly the cardiac muscles. Okay, and due to the cardiac muscles, it is leading to the heart failure. Okay, the prognosis, ultimate prognosis is heart failure here, right? Or the sudden cardiac death. And it could be defined as structural or functional abnormalities of cardiac muscle. So remember this, when we are talking about cardiomyopathy means myocardium. When you see the myocardium, means myo means muscle, as we all know, cardium means cardiac muscles. Okay, cardiac means cardio, I mean the heart muscle. So cardiomyopathies means abnormality in heart muscles. Okay, abnormalities in heart muscles, like heart muscles can be restrictive, heart muscles can be hypertrophic, heart muscles can be dilated. Multiple things can happen due to different etiologies, and that can lead to heart failure or the sudden death, right? So according to American Heart Association, the guidelines says that cardiomyopathy is a heterogeneous group of diseases of myocardium, cardiac muscles, associated with mechanical or electric dysfunctional. Okay, electric dysfunction is nothing but arrhythmias. Okay, I mean there are the two systems. Okay, I'll define it again. So if like heart, suppose your heart is a house, right? Suppose your heart is a house, and there are two very necessary things in the house. Okay, there are two very necessary things in the house. One is light system, like electricity system. Another thing is water system, like circulatory part, like circulation, right? Water system, water pumping system. So there are two things. One is cardio, coronary arteries, that is your pumping system, that is your circulation system, which provides the water. I mean in the heart it is blood, which fulfills the nutrition, which fulfills the circulation, everything. Okay, that is your water pumping system. Another thing is electric system provides you electricity to run your home appliances, to run your different parts of the things. Okay, so guys, please mute yourself, or I'll meet you all, so you can just write your answers. Okay, no, it won't be good. So I'll be talking, so you can also talk, but try to put yourself on mute if you are not talking. Okay, so so there are two things. One is your blood pumping system, that is coronary arteries. Another thing is electric system. Electric system means your arrhythmias. Okay, which I mean the dysfunction in dysfunction in your electric or conduction system. In heart we call it conduction system. Okay, conduction system means all the there are the nerves, there are the conduction system to entire heart, the entire part, or the different parts of the heart, like to left ventricle, left artery, or left atrium, and left ventricle, left right ventricle. There are the different junctions, blocks, and multiple things which diverts the conduction system to different parts of the heart. Okay, so the conduction system is the electric function of the heart. And if you get dysfunction, like the breakage of the nerves, breakage of the muscles, so the electric system, the conduction system get disturbed. Okay, if it get disturbed, that can also lead to the cardiomyopathies. Okay, so these two things, mechanical means your circulation part also can get disturbed by heart attacks, the myocardial infarctions, by foreign particles, by strokes, by PVDs, PADs, toxicity, the toxic substances, or by the injuries. Multiple things are there. Okay, so at the end, your electric or the mechanical functions will be varied or will be disturbed. Okay, and once they are disturbed, they will exhibit the inappropriate ventricular hypertrophy or the dilation. Ventricular hypertrophy means, usually, at the end, how the heart failure develops when we have the problem in our ventricles, because ventricles are the main parts which supplies the blood, to either your lungs or to the body. So your right ventricle supplies the blood to your lungs, and the left ventricle supplies the blood to your entire body, right? So mainly these hypertrophies or dilation. Hypertrophy means kind of swelling, I'll say, kind of increased mass in your myocardium. Increased mass means the due to these effects, due to these circumstances, due to these the problems or etiological factors, the mass in your heart wall, okay, heart wall will increase. That is called hypertrophy. Dilation means the mass of the heart wall, like the myocardium, will decrease in the volume. Okay, so these two terms will be defining your entire cardiomyopathies: dilation and hypertrophy. Okay, so there will be the various etiologies. So let's read it again so you can understand it easily. A heterogeneous group of diseases of myocardium associated with mechanical and or electric dysfunctions, as I told you, both. Okay, or the one that usually exhibit the inappropriate either hypertrophy or dilation, that could be due to variety of etiologies that are frequently genetic. Okay, so cardiomyopathies are either confined to the heart or a part of generalized systemic disorder. Okay, part of heart, I'll come to that point, part of heart or the systemic disorders. Okay, then often leads to cardiovascular death or progressive heart failure. As I told you, there are two ultimate prognosis of cardiomyopathies. One is cardiovascular death, other is heart failure. Okay, so this definition was given by Maron in 2006, and that is adapted by American Heart Association. So I hope the definition of cardiomyopathies is clear. It is very complex to understand, but I hope you understood that this is the problem of myocardium, means the cardiac muscles, due to the structural or functional abnormalities, and that leads to the ventricular hypertrophy or dilation. Okay, and it often leads to cardiovascular death or progressive heart failure. So just read the red part. Okay, read the highlighted part here. Cardiomyopathies are the diseases of myocardium by structural or functional abnormalities, exhibit inappropriate ventricular hypertrophy or dilation, often lead to cardiovascular death or progressive heart failure. So very easy to understand. Okay, guys, right. So let's go to next slide. Let's understand more. So here, classification. The initial classification of cardiomyopathies was into two categories. One is primary cardiomyopathy, another is secondary cardiomyopathy. So the primary cardiomyopathy was confined to the cardiac muscles. Okay, so based on the, as I was telling, heart wall or other systemic disorders. So one will involve definitely cardiac muscles, other will involve cardiac muscles, but after any other systemic disorder. In the hypertension, correct? As we have learned in the hypertension, one is primary hypertension, one is secondary hypertension. So secondary hypertension means it leads, or it is a result by, or it is a result of another problem. It is a result of another disorder. Similarly, in cardiomyopathies, the secondary cardiomyopathies are the part of other systemic disorder that is affecting multiple organs, not only the muscles. Okay, but the primary cardiomyopathies means only affecting the cardiac muscles. Cardiac muscles are the first target to affect. Understand, guys? So nowadays there are new and more appropriate classifications are used. Not only these two, primary and secondaries are very kind of very what we say, the initial part of the classifications based on the involvement of cardiac muscle, how they are involving the cardiac muscles. If the problem is starting from the cardiac muscle, or it is involving the cardiac muscle as a part of other problem, right? So primary cardiomyopathy and secondary cardiomyopathy. Now let's come to the other problems. Okay, let's come to the other classification where you will understand that it properly. See, look at this. Okay, look at this. It is very, very important to understand here. Cardiomyopathies. One is HCM, as we can see here, DCM, ARVC, RCM, unclassified. Okay, so these are the five most important terms, and those are again divided into different things. So how many of you know about HCM and DCM, or arrhythmogenic right ventricular cardiomyopathy, or respiratory
Hypertrophic
cardiomyopathy?
cardiomyopathy.
How many of you know about all these five, or four? Three?
Sir, I just know only the definitions. I don't know apart from that.
Okay, did you hear about ARVC before, guys? Did you hear about RCM before? HCM, DCM? How many of you have heard of HCM word before? Hypertrophic cardiomyopathy. Guys, raise your hands, or mention in the comments, please. Three. Dr. Venkat. Okay. Anyone else? HCM. Abdev Hussain. Okay. Okay, so I mean, very less people, I think. Anyone in the YouTube who knows these cardiomyopathies, or any of the cardiomyopathies, please? Okay, Stuti knows about HCM, DCM, ARVC. Fantastic, nice. Okay, many of you knows about three or two. Ultimate DCM. Okay. Stress-induced dilated cardiomyopathy. Okay, what is the other name of stress-induced dilated cardiomyopathy? Guys, can you tell me? Anyone? The other synonyms for stress-induced dilated cardiomyopathy. And what is it? Let's discuss stress-induced dilated cardiomyopathy. Abdev Hussain, you raised a very fantastic question here by keeping this name here. What is stress-induced dilated cardiomyopathy? Can someone tell me about it, please?
Sir, I'm not sure, but is it broken heart syndrome?
Yes, it is broken heart syndrome. Perfect. And other thing? There is one more term. Broken heart syndrome. Perfect. Okay, I'll write broken heart syndrome. Okay, that is the another term for stress-induced cardiomyopathy. One more term is there. Okay, so now you have understood the broken heart syndrome. It is very common, broken heart. I mean, let's drop the syndrome from here. Broken heart, right? So what is broken heart in general terms, guys? Please discuss, guys. It's very important to understand. It's very important to understand for your families also, for your the people who are sensitive more in your families, or who are in the elder age. I'll share all the documents with you for cardiomyopathies, all the references I referred. Don't worry at the end. But let's discuss, make it more fun. Broken heart. Okay. Takotsubo cardiomyopathy, fantastic. Another term for stress-induced cardiomyopathy is Takotsubo cardiomyopathy. Okay. Yes. So broken heart syndrome or Takotsubo. Correct. Fantastic. Now tell me, what is broken heart? Okay. How many have you gone through the broken heart? Guys, come on.
Can I speak?
Yes, please.
I think so. Takatsu was seen in critical care patients where a critical illness causes stress, then causing cardiomyopathy.
Yes.
So a lot of times in Takatsu was very common in critical patients.
Critical patients. Yes. True. Okay.
That could
Broken
be
heart.
due to the left ventricular dysfunction. The left
Yes.
ventricular dysfunction.
See, all cardiomyopathies are related to almost all are related to left ventricular dysfunction, which leads to heart failure. Okay, so I was talking about broken heart. That's very interesting, and I'll tell you the amazing facts about broken heart, guys. Please tell me, what do you understand by broken heart? Here, in aspect of cardiology, not an aspect of the romantic dates and broken heart by the girlfriend or boyfriends. I mean, that could be one of the reason, by the way. Okay, that could be one of the reason for broken heart syndrome, but that's not the main reason. See, I'll tell you. I don't think you will speak up. I'll tell you. So, how it affect the people who are more sensitive, the people who are in the elderly age, or people who are more attached to something. Okay, where they're more attached, usually with their families, right? With their families, with their son, daughter, granddaughters, grandsons, with their parents, right? They're more attached to them. So usually when the patients are having a family history of any kind of cardiac disease, just listen to it and keep it in mind for yourself. When you have a family history of cardiac problems, or you have any underlying heart disease like congenital heart disease you had, or any kind of other heart disease, you have arrhythmias, blood pressure, the hypertension, or maybe some other problems. Okay, so now I'll shift to the other scenario. Okay, then I'll come back to that. Suppose uh, you know uh, when someone dies. Okay, so we don't tell the immediate families immediately, or we just don't tell the people who are more attached. We don't tell them directly, like, okay, someone has died. We tell, okay, you come over and there is a problem or something. We make excuses. We don't tell them directly that, okay, something very bad has happened or something very happy things are there. Not only, it is not only about the sadness, it is maybe it could be related to the happiness also, the extreme happiness or extreme sadness, okay, or extreme disappointment. Remember this: extreme disappointments, extreme sadness, extreme happiness can lead to broken heart syndrome or the stress induced cardiomyopathies, and that can lead to sudden cardiac death. Okay, that can lead to sudden cardiac death in case, usually in case, when the patient or the person is having underlying cardiac disease or having any kind of family history for cardiac problems at the early ages. Okay, so these are the facts, these are the etiologies, the major etiology for stress induced cardiomyopathies. So these type of patients, they cannot handle that stress. Okay, stress means maybe it is because of the extreme happiness, but the cardiac muscles cannot bear that extreme stress of happiness or maybe sadness or the disappointment, and they usually stopped working. Yes, they suddenly stop working. Okay, and the people can lead to sudden cardiac death. That's why, this is this is a I mean, our older people usually tell, our elderlies, our people around in the villages, in our cities, wherever, I mean, it's common thing. We don't tell them such things directly. Okay. And when we come to the technical part or the scientific part, that is broken heart syndrome. That is stress induced cardiomyopathy. Understand? Does it make sense for you guys? You understand that?
Yes, sir.
Yes, sir.
Great. So, okay. And that is also called as Takatsubu, as Abde has told. Like, it is, Takatsubu is a part of stress-induced cardiomyopathies, and that stress is due to the other problems. Other problems means other, dysfunctions, or other, multiple organ involvements. Like, if you have any other cardiac problems, like if you are going through the heart attack, if you're going through the myocardial infarction, and then suddenly you have cancer also, or you got some other problems also, and then it stresses, I mean, the entire thing, entire scenario, entire pathophysiology stresses your cardiac muscles, and in that case cardiac muscles are not able to take up this stress, and you will lead to either heart attack, I mean, sorry, heart failure, or the sudden cardiac death. Okay, you will lead to death, the patient will lead to death, right? So this is the stress cardiomyopathy. Now let's come back to the classification. HCM, as you can see on the screen, HCM reflects, or HCM stands for hypertrophic cardiomyopathy. Hypertrophic, as I told you, there will be the increased mass in volume. Okay, increased mass in volume. Usually we see outside, I mean, outside the heart, we call it, okay, it's fat. I'm getting fat. My skin is going thick. So that is about the heart wall inside. Okay, that is about the heart wall inside. And so that is about the heart wall inside, right? So due to certain reasons, due to the infections, due to the the toxic substances, due to the, who's this guy?
Sir, your voice is breaking.
Ah, yes. I actually kept on mute. Someone was raising this horn honking. Okay, so hypertrophy means increased mass, increased mass of the muscles in your heart wall. Okay, dilated cardiomyopathy means the chambers, like your left ventricle or right ventricle, usually left ventricle will dilate. Okay, as we have seen in our you know heart failures. Okay, dilated cardiomyopathy. Arrhythmogenic right ventricular cardiomyopathy, ARVC. Okay, ARVC is arrhythmogenic right ventricular cardiomyopathy. So right ventricle cardiomyopathy means the arrhythmias usually generates, we have our original pacemaker, we have our automatic pacemaker in our, okay, so where is our the, what we say, the automatic pacemaker, or what we call it, the pacemaker in the heart, where it is actually, guys, can you tell me where it is located?
Right side, right.
SA
Right,
node.
Atrium.
SA node, right atrium, absolutely. SA node is located or situated in our right atrium, right? So from the right atrium, usually in the conduction system, the waves are generated. Okay, waves are generated from the right atrium, and it goes to the right ventricle through the muscles, through the septum. Okay, through the septum it goes to the right ventricle, and there, usually from there the arrhythmias are generated. Arrhythmias means if the conduction system is affected, if the conduction system is disturbed, if the muscles are damaged, if the nerves are damaged. Okay, due to the certain things, arrhythmias are generated from the after the SA node, because SA node is the generation of the entire waves, or entire the frequencies, or in the conduction system. But usually all the arrhythmias starts from the right ventricle. because this is the main area from where they enters into the proper stuffed myocardium. Okay, and if such injuries or such thing happens in right ventricle, then you will get arrhythmias. Okay, so due to arrhythmias also, your when your conduction system is not properly working, then your muscles, your cardiac muscles, your myocytes start changing the structure. Okay, structure that structure could be either reversible or irreversible. Remember guys, these structural changes, structural defects might be reversible or irreversible. Okay, that's another thing. Reversible or irreversible is another things. But due to the arrhythmias, due to the conduction system defect due to the conduction system defect due to the arrhythmias, that can happen, that can lead to the cardiomyopathy. Okay, cardiomyopathy means either hypertrophic or dilated. It does not matter. Okay, usually in arrhythmogenic it is dilated. I mean, in some it is hypertrophic also. So arrhythmogenic right ventricular cardiomyopathy is related to arrhythmias. It is generated by arrhythmias, and arrhythmias means the defect in your conduction system. Defect in your conduction system, right? So arrhythmogenic right ventricular cardiomyopathies are one of the another type. Then RCM. RCM is restrictive cardiomyopathies. So what do you understand by restricted cardiomyopathies? Restricted cardiomyopathies means when your circulation system is restricted due to maybe valvular problems, due to maybe hydrated cyst, due to maybe cardiac cancers, due to maybe other problems. Okay, so the flow of the blood, flow of the circulation is affected. Okay, circulation is affected, that is called restricted cardiomyopathy, and that also turns into the cardiac death, that leads to cardiac death ultimately. And there are some unclassified cardiomyopathies. There are almost 100 types of cardiomyopathies. Okay, 100 types of cardiomyopathies. These four are top cardiomyopathies, including there is one more, non-compaction. I'll come to that in the next slide. But majority are HCM, DCM, ARVC, or RCM. Okay, hypertrophic cardiomyopathies, dilated cardiomyopathies, arrhythmogenic right ventricular cardiomyopathies, or arrhythmogenic cardiomyopathies, if you say, that's fine. Okay, then restrictive cardiomyopathies, and there are unclassified. So these are also divided other types like familial or genetic. One is like which are usually generated, or usually what we say, the main etiology of these is genetic. And there are non-genetic cardiomyopathies, those are called as idiopathic cardiomyopathies. Okay, so let's check here now. Primary cardiomyopathies, okay, predominantly involving the heart, so not generated by other problems. Look at this. This is, here we are defining all the things. So genetic, mixed means genetic and non-genetic, and other is acquired. Okay, remember these things. One is totally genetic, one is acquired, one is mixed, where you can have genetic reasons also and non-genetic reasons also. So in the genetics, usually we have HCM, this is hypertrophic. In mixed, it is DCM. DCM could be genetic or could be due to other reasons also, like arrhythmogenic or something, right? So genetics could be HCM and arrhythmogenic, or LVNC, what I was talking about, this left ventricular non-compaction. Okay, and then there are glycogen storage also. Glycogen storage in your cardiac muscles, that also can cause hypertrophy. Okay, that also can cause hypertrophy and cardiomyopathy, that leads to cardiomyopathy. Conduction defects, again it is your arrhythmogenic. Then mitochondrial myopathies means changes in your RNA. Okay, changes in your RNA. And then there are some ion channel disorders like Brugada syndrome, LQTS, SQTS. These are also related to arrhythmias, but defined as different cardiomyopathies. Okay, defined as different cardiomyopathies. What is LQTS? LQTS is nothing but long QT syndrome. Okay, long QT syndrome. Short QT syndrome is SQTS, and CVPT is nothing but catecholamine polymorphic ventricular tachycardia. So the tachycardia which is induced by catecholamine deficiencies or high references or high levels of catecholamine in the circulation or in the body. Okay, so nothing much to understand here. This is simple. Genetic, it could be HCM, ARVC, LVNC, there is left ventricular non-compaction, and then glycogen storage. Remember these things: glycogen storage, conduction defects, and maybe due to the mRNA changes. Okay, that comes to the mitochondrial myopathies. And then if it is related to, again, like your arrhythmias, then LQTS, SQTS, Brugada syndrome, and your CVPT. Okay, mixed. Let's come to the mix later. First, acquired. Acquired means inflammatory. Inflammatory could be due to the viral infection, or toxic substances, or the bacterial infection. Then Takotsubu, stress provoked, right? You see, look at the term here: stress provoked, stress induced, stress provoked cardiomyopathy. Another is peripartum cardiomyopathy. Due to pregnancy also people get heart failure. Okay, that is called as peripartum cardiomyopathy. There are the cardiomyopathies which are tachycardia induced. Okay, tachycardia induced cardiomyopathies are not genetic. Okay, then there are the cardiomyopathies in the infants of insulin dependent diabetic mothers. Okay, infants of insulin dependent cardiac mothers are taking birth with the cardiomyopathies, right? So these are the acquired, which do not have genetic problems. And when we come to the mixed, so restrictive, which is non-hypertrophied or non-dilated, that could be maybe genetic or acquired. DCM also could be genetic or acquired. Okay, remember this. So this is the major classification of your cardiomyopathies. One is genetic, mixed, or acquired. Okay, then let's go to the next slide. So prevalence of cardiomyopathies, you can understand how common these are. So most common things are dilated, hypertrophic, restrictive, and arrhythmogenic. Okay, if you look at the dilated and hypertrophic, almost similar. Okay, almost similar. In childhood, it is definitely uncommon. All are uncommon in childhood. But in the adults, dilated cardiomyopathy could be found in 1 out of 250 people. 250 to 500 people. Okay, 1 out of 250 to 500 people, you can find the dilated cardiomyopathy or the restrictive cardiomyopathy. Okay, dilated cardiomyopathy or restricted cardiomyopathy you can get in 1 out of 250 to 500 people. When we comes to the restricted cardiomyopathy, it is uncommon, but usually it is 1 ratio with 1500 to 2500. Okay, 1 ratio with 2000, if we can say, similar to arrhythmogenic right ventricle cardiomyopathy. This is also 1 ratio 2000 to 5000. Like 1 out of 2000 to 500 people can get the arrhythmogenic ventricular cardiomyopathy, because arrhythmias are common. Okay, so this problem is not that uncommon. Cardiomyopathies are common. Okay, because if you look at the Indian scenario, India has 1.4 billion population. So we have a lot of people, and we get a lot of cases of cardiomyopathies as well. So here, wonderfully defined, you can understand the structural changes. First, look at this. Okay, let me come up with this presentation view pointer. Yeah, see, normal. This is a normal heart. You can see this shows your blood flow. This is your right atrium, right ventricle, left atrium, this one. This is left ventricle. Okay, look at again. This is your right atrium. Okay, receiving the blood from the body. This is your right ventricle, receiving the blood from right atrium and sending this impure blood for the purification to the lungs. Okay, from the lungs, the blood is coming to, from here, the blood is coming from the lungs to your left atrium. Okay, and from that left atrium, it is going to the left ventricle. So if you look at the wall, look at the heart wall of left ventricle, it is quite thick. Okay, why it is thick? Because left ventricle has to do a lot of work. The highest workload or the energy is needed by your left ventricle. Why it is? Because it has to pump the blood at every stroke to the entire body. Okay, right. Now look at the First thing, hypertrophic cardiomyopathy, which is 1:200 to 500. So hypertrophic cardiomyopathy, if you look at, hypertrophic means increased mass of the wall. So if you look at this portion, the septum between left ventricle and right ventricle. Okay, this is the septum between left ventricle and right ventricle, and here you can see the changes. The mass of the septum has increased. Okay, the volume of the mass between right and left ventricle has increased. Okay, has increased. And due to this, what has happened, why these cardiomyopathies lead to heart failure? Why? Because see, look at this, it has decreased the volume of your left ventricle, and the pumping system will be affected, and the amount of blood which is needed persistently to your entire body will be reduced. That means your ejection fraction will be reduced. Understand, guys? I hope you understand clearly here how the hypertrophic cardiomyopathies or the cardiomyopathies affecting the heart failure or affecting the heart and affecting you. Okay, so these are leading to the heart failure. This is the pathophysiology, or this is the total connection between cardiomyopathies and the heart failure and you, right? And then let's come to dilated cardiomyopathy. So it is kind of, hypertrophic cardiomyopathies are kind of what? Can you tell me, how can you relate to the heart failure? In heart failure, we spoke about systolic dysfunction and diastolic dysfunction. So this is a kind of, diastolic dysfunction. Or if we tell about preserved ejection fraction and reduced ejection fraction. So here the ejection fraction is preserved. Okay, here ejection fraction is preserved, but your volume of the blood, amount of the blood is not proper. In the dilated cardiomyopathies, if you look at this, the muscles or the cardiac muscles, the myopathies, okay, in the myopathies, it has decreased. I mean, the mass has decreased and the volume of the blood is too much, but the muscles are not able to pump the enough blood. Okay, understand? This is the muscle which has decreased the mass and dilated. Okay, dilated. Blood amount is okay. Blood amount is okay inside the left ventricle, but when it comes to the pumping system, the muscle or the left ventricle is not able to pump the enough blood to your body. Okay, that is called dilated cardiomyopathy. Like the left ventricle has dilated, the muscles have been dilated. Here muscles have been hypertrophic. Okay, muscles have been hypertrophic, means the mass has increased, here mass has decreased. So this is the major difference. These two are totally opposite. Hypertrophic and dilated cardiomyopathies are totally opposite. Okay, then if we look at the arrhythmogenic cardiomyopathies, look at this arrhythmogenic. If you look at these white spots, okay, can you look at these white spots in the muscle? See, size of the left ventricle, right ventricle is okay, but these white spots says that the conduction system is not proper. Due to the conduction system defect, due to the deficiency in the conduction system, your entire muscle is damaged, and due to the muscle damage, your your muscles or the heart wall is not able to pump the proper amount of blood. Understand that? I hope it's clear. So restrictive means the heart looks fine, but due to the uncertain problems like blocks, like myocardial infarctions or like valvular heart problems, the blood flow is restricted. Okay, in LV non-compaction means your left ventricle, LV non-compaction means left ventricle, inside the left ventricle, the wall of the heart, okay, it gets the tentacles type of structures. Okay, the structure of the entire wall or entire I will say the myocardium of the left ventricle will change. Okay, it shows the tentacle type of structures, or it gets the some different kind of structures, usually tentacles, which actually occupies the volume of left ventricle, and when these tentacles or these structures occupying the volume, occupying the volume of left ventricle, means the blood inside the left ventricle, the amount of blood inside the left ventricle will be reduced. Okay, and your heart will not be able to pump the enough amount of the blood. Got my point, guys? So these are the cardiomyopathies and their pathophysiologies, how they usually works and how they usually look. So here you can see all the structural changes also. Okay, this slide is very important to understand. So I hope you understood, guys. Okay, any question, guys, here? Anything you want to ask me, anything you want to discuss here, please tell me. Any questions, any queries, anything you want to understand more? Did you understand everything here? I mean, I tried to make it very clear, but if you have any questions, you can. Okay, Barka Chaturvedi. Anything else who wants to explain it again?
Yes, sir. LV non-compaction.
Okay, LV non-compaction is when your left ventricular, inside the left ventricular, there is the normal surface. Okay, normal surface means not exactly the plane surface of the heart wall. Okay, there are the grooves, but in the LV compaction, the surface get tentacle type of structures. Okay, inside that the myocardium inside the LV gets the unusual structures. Those unusual structures are usually tentacle type of structures. Okay, and those tentacle type of structures are occupying your left ventricle. Suppose there is a room. Okay, there is a proper room and proper working for that room. I mean, there is a room enough to sit many people. Many people means, okay, you are 10 people, you are sitting in an office. I'll give you that example. There is an office. Okay, there's an office, and you are 10 people, you are sitting inside the office, right? And that office is completely occupied by you, and it is very good for you, and you are working enough in that office. Suddenly you feel like your office, inside your office, there are someone put the unusual structures, like someone put these unusual structures, or I'll say the unusual decoration. Okay, unusual decoration, some tables, some kind of other things, flower pots everywhere, right? So you will not get that place. Okay, you 10 people cannot sit there, you 10 people cannot work there, because that area is occupied by other structures. Okay, so similarly in the left ventricle, what happens, usually the left ventricle is made to circulate the blood, to pump the blood to the entire body, like left ventricular. So in the left ventricle, suddenly in the non-compaction phase, there are the unusual structures which are coming out from the wall, which are coming out from the myocardium, left ventricle myocardium. Okay, and those tentacles or those structures are occupying the actual volume of the left ventricle. So left ventricle, I mean, the amount of blood which was normally there, is not now. I mean, that volume will be definitely reduced, because the place is occupied by these tentacles, by these other unusual structures which has come out from the wall. Okay, so that's how it is compacted. Your left ventricle is compacted, right? Left ventricle is compacted by these tentacles or by these structures. Okay, so that is called LV non-compaction, and that reduces the amount of blood, whether your ejection fraction is normal or not normal. The amount of blood which is coming out is not enough for the body. Okay, so that leads to heart failure again. Okay.
Yes, sir.
Okay, so great. Now, okay, so someone asked about the HCM and DCM. Okay, so HCM means hypertrophy. Hypertrophy is like increased mass of the muscle. Okay, increased mass of the muscle, which will enhance the size of the muscle, and it will lead to the heart failure. Dilated means the mass of the muscle will be reduced, and the volume and the actually the structure also will not be stiff, or what would you say, stiffness. Okay, so in the dilated, the stiffness will also go along with the mass. In hypertrophic, the stiffness will come with the mass. Okay, there will be more excessive stiffness of the muscle. Excessive stiffness along with the increased mass. In dilated cardiomyopathy, the stiffness also will go, so the left ventricle will be dilated. Okay, so now how to catch up the sign and symptoms, or how to catch up these cardiomyopathies? First of all, there are general symptoms. General symptoms. One is cachexia, then fatigue, dyspnea. Patients are unable to tolerate lying flat, so they need to be propped up by pillows. Okay, plus any other sign and symptoms which are their downside. So can someone tell me what is cachexia? Guys, what is cachexia? Come on, you should be prompt in answering. You should not search in the Google. Yes, guys, please.
So cachexic person who cannot take food.
No. No. I mean, it is one of the outcome, but cachexia is not exactly.
And cancerous patient who cannot take orally, like that.
Yes. So cachexia is not exactly taking food or the cancer patients or something. Cachexia, I'll tell you the definition. I'll tell you the word. What is exactly the cachexic? So the cachexia is extreme weakness. You even don't feel to have anything, have food. You don't even feel to walk. You don't even feel to sleep down. You don't even feel to stand up. Okay, cachexia is called as extreme weakness of the reason could be anything. It could be chronic illness, it could be your muscle weakness, it could be drug abuse, it could be anything. Cachexia means, another terms, it is extreme weakness where people even don't want to eat, don't want to walk, don't want to stand up. So it is kind of extreme weakness. Okay, extreme weakness in the body, right guys? Definitely cachexic people, they don't want to eat also, so they are like they get tired after eating even one chapati or two spoon of two spoon of the rice or food. That's why they reduce their appetite, not because their appetite is actually reduced, because they are tired of doing something. They are tired of eating, they are tired of standing, they are tired of sitting. So cachexia means the extreme weakness of the muscles. Okay, clear?
Sir,
Yes.
it can lead anemia.
Yeah, it could be anemia, it could be anemia, it could be cancer, it could be extreme weakness. It could be your chronic illness. Reason could be anything. Okay, so these are the general sign and symptoms of cardiomyopathies. When we come to the specific organs, first of all, let's look at the neck. Distended neck, veins from raised venous jugular pressure, definitely major sign of heart failure. Okay, major sign of heart failure, increased or raised venous jugular pressure, JVP. Lungs, common feature of heart failure, pulmonary crackles. Gastrointestinal, enlarged liver, ascites. Pulse will be irregular. Extremities, patient may get the peripheral edema. Okay, on palpation, there'll be the third sound. Okay, can someone tell me what is third sound? Okay, on auscultation, valvular murmurs will be there, gallop rhythm will be there, extra hard sound. What I'm talking about is third sound. Okay, so there are lub dub, do the sounds when you look at the heartbeat, when you hear the heartbeat. But in cardiomyopathies, in heart failures, there is the another sound. There is the third heart sound. Okay, that is called third sound of the heart. Okay guys, So these are the major sign and symptoms to understand the cardiomyopathies. And cardiomyopathies means the heart failure. I mean, not exactly the heart failure, but it leads to heart failure. So most of the symptoms will catch up with heart failure, will mimic the heart failure. You have to be very clear, okay, in the sign and symptoms, guys. Okay, I hope it's clear. It's very simple. Yes, S3 gallop, S4 sounds. No, see, S3 and S4 are not similar. These are the different names. You can see S3 sound 3, sound 4. So there are the different sounds. There are two major sounds. One is lub dub. When you have cardiomyopathies or you have arrhythmias, you get sound 3 sometimes, S3. When you have pulmonary hypertension or when you have, you know, cardiac height, I mean hydrated cyst in the heart, you get S4 also, sound 4 also. Okay.
Excuse me, sir. How
Yes, please.
S3 and S4 are different from gallop sounds? Are there
No, I mean, not exactly
gallop?
different from the gallop. Not exactly different from the gallop.
Okay, sir. Thank you, sir.
But the sound are different. I mean, in the hearing. Okay. S3 and S4. Okay. So now I hope you understood the sign and symptoms. Let's go to the diagnosis part. These are okay. So before diagnosis, let's understand the common causes. This is for the common and majority for DCM, dilated cardiomyopathy. Okay, these are the causes for common HCM and DCM, and you know, majorly for the dilated cardiomyopathy. So you know, these are the genetic causes you can see in your left, and you know, the examples of the causative factors, examples or the causative factors in the right side. So as I told you, genetic, it could be cardiac genetic defects, okay, like you know, beta myosin heavy chain or troponin T or other things. Infections like viral, fungal, parasitic, rickettsial or protozoal diseases. Autoimmune like Giant cell myocarditis, non-infectious myocarditis, polymyositis, or you know, dermatomyositis, or there are other things also. You know, SLE also, systemic lupus erythematosus also, sarcoidosis also. These are autoimmune disorders which can cause the DCM or HCM, and you know, these are the common problems. Toxicities like alcohol, extreme you know, drunkards or you know, the alcoholic peoples can easily get the DCM. Cocaine, amphetamines, and iron overload also can cause DCM. Nutritional deficiencies like selenium or thiamine, zinc, or copper deficiencies, extreme deficiencies, not the normal deficiencies, but the extreme deficiencies of the selenium, thiamine, zinc, or copper can cause this. Okay. And then the drug induced antineoplastics, usually usually cancer drugs are the responsible factors for most of the cardiomyopathies or most of the problems, right? Drug induced cardiomyopathies, right? Those are the drug induced cardiomyopathies which can be done by the, you know, paclitaxel, anthracyclines, alkylating agents, or you know, the psychiatric drugs like clozapines, olanzapines, or you know, the chloroquines or you know, tretinoins. Sometimes you know, chloroquines are also, you know, chloroquines are actually, you know, responsible for LQTS or SQTS, like short term, you know, T wave or long term T wave, you know, long T wave or short T wave. So that's why chloroquines are should be given with the proper restrictions, proper monitoring. Then there are other endocrine and pregnancy related problems. Hyperthyroidism in the pregnancies. Okay, hyper or hypothyroidisms, usually Addison's disease, or you know, pheochromocytoma or acromegaly, diabetes also, and then peripartum. I mean, the pregnancy itself could cause the, you know, cardiomyopathies. Then inborn errors of metabolism like fatty acid inoxidations or, you know, glycogen storage diseases. So these are genetics, definitely, as we have seen in the genetic cardiomyopathies, right? And other electrolyte abnormalities. So these are the major problems. Okay, guys. So here, these are the common problems. And for RCM, majorly infiltrative diseases like amyloidosis, sarcoidosis, or primary hyperolexuria. And then storage diseases, as we have seen last, glucose storage diseases, Fabry's disease. Anyone can talk about Fabry disease? What is Fabry disease, guys? It's very common. Can you talk about Fabry disease? Can someone tell me about the Fabry disease? Normal in the layman language. Please tell me about the Fabry disease. Okay, so all of you, none of you knows about the Fabry disease. Okay, Fabry disease is the unusual storage of the fat. Okay, unusual storage of the fat. There is a specific term, you can search it, and you can understand the unusual term for the fat, unusual type of the fat. Okay, that starts with the gallio. Okay, so Fabry disease is the unusual storage of the fat in your body cells. Okay, guys, Fabry disease, you should take out these terms what I'm teaching. Okay, when I'm teaching, I know about all the terms what I am teaching, because I know you can ask any unusual question to me. So I expect you also read all the terms what I am teaching, because see, that's how we increase our knowledge. If I'm teaching cardiomyopathies, that doesn't mean that I'm just teaching cardiomyopathies. I learn a lot of things. I learn about amyloidosis, psychosis. I learn about Fabry disease. Or if I don't know about Niemann-Pick disease, I learn about Niemann-Pick disease, because I know I'm teaching, the youngsters, I'm teaching the people who don't know anything, right? So they can ask me any question. So I learn from these terms, and I explore these terms, right? And then I learn new things. And that's how I increase my knowledge, right, guys? So you also can go through these terms, you also can search for these terms in Google, learn about these, go for the papers, and if you found interesting, go for it, learn it. Okay, these are very important. These all are health related terms. You are the family people, you are the medical people, nursing people, or your health science people. You must know all of these things, right? You all should be aware of these things. That's how we how we get expertise in any subject. If you are family people, you should be expertise in the pharmacotherapy, in the medicine, right? So that's how we get expertise. That's how we make ourselves to make others understanding, like I'm teaching you. So if you are not going through all the terms, what is methyl saccharide, what is argatamines, what is bisulfan, or what is antineoplastic drugs, so you have to understand these all things. Okay, so these are the genetic causes for RCM, restricted cardiomyopathies, and in common endomyocardial problems. Drug induced, there are the drug induced restrictive cardiomyopathies. Here drugs are not different. Here again, the antineoplastic drugs, and some psychiatric drugs, and then serotonin, majorly serotonin and methylsaccharide causes the RCM, restricted cardiomyopathy. So this is the diagnosis in common. First of all, you should understand the history, personal history, then symptoms, physical examinations of the patient, as I told you, S3 gallop, or the crackles, or the swellings in the ankles, the heart failure sign and symptoms, and then you can go for the family history. So guys, a very important thing to understand here: if you have any kind of sudden death history in your family, okay, anyone, I mean, if you look around, if you found in your relatives, families, or anyone, if you have the history of the sudden death, then definitely after age of the 40 or 35, everyone must go for a checkup, like echocardiogram and all, right? That's very important, to just for a body checkup. Okay, that's very important, because it could be HCM, it could be any other problems which led to the sudden cardiac death, not unusual regions. I mean the unusual region, not the usual regions, right? So testings usually done by ECG, echo, and cardiac MRI, cardiac magnetic resonance. And there are the genetic if majority of the cardiomyopathies are genetic related, so genetic testings for sarcomeres mutation, right? 30% of the patients, they get genetic mutations. And then you can check in the patients. If they get any unusual results, then you can definitely go for the family member cascade testing also. Okay, and if you find out something in your echo or CMR, then definitely go for the obstruction test, or obstructions arrest, like you can check for other things also. So majorly ECG, echo, and cardiac magnetic resonance, and then genetic testing. These are the four important diagnostic parameters for any kind of cardiomyopathies. Okay, so management, there are different for HCM, for not this is not for HCM, guys, this is for peripartum. Sorry, one sec, let me change it. Break. Okay, so this is for, there are no specific treatments, but there are the things which will, you should understand. Like if you're talking about hypertrophic cardiomyopathies, then, you should definitely look for the prognosis. And if there are the chances of sudden death, I mean, there are the chances of sudden cardiac death in all the cardiomyopathies. So you should go for the risk stratifications. If you have anything, related to that, other problems like, myocardial infarctions or relatively valvular heart disease or anything, you should correct it well. Okay, so then it will help you. And ICDs you can put in the patients with arrhythmia problems, or the pacemaker. So that will help you, prevent the sudden death in hypertrophic cardiomyopathies. And if you have the progressive heart failure due to the HCM, then definitely go for negative inotropes. And if the hypertrophic cardiomyopathy is much, then go for surgical myectomy. Surgical myectomy is the removal of the extra mass. Okay, removal of the extra mass in your mass volume in your myocardium. Okay, and there are other ASAs. Aspirin could be given as selective alternatives. Okay, and if there are progressive heart failure which is non-obstructive, then go for, like if it is preserved ejection fraction, then go for the heart transplant, or not direct heart transplant, but you can go for the beta blockers, or other heart failure therapies. And if it is atrial fibrillation, due to the HCM, then definitely go for the atrial fibrillation management by catheter ablation, or maybe the MAGE procedure. If the myosectomy is planned, then you can go for anticoagulations also, and the stroke prevention, right? I mean, these are symptomatic treatments, no specific treatment. HCM, major treatment is myectomy. So myectomy is like the removal of the excessive mass from the wall of the heart, right, guys? And pregnancy, if it is pregnancy related, like, peripartum cardiomyopathy, then definitely, induction of the lung maturation will be there in the fetus. Okay, and then, the patients will be developing heart failure. So keep it the goal of, reducing the heart failure, and make a proper team of cardiologists, obstetrician, and neonatologists who can take care, and anesthesiologists, cardiac surgeon, operating room coordinators, because these all are needed at that time. So if the fetus in that case is non-viable, then give the maximum heart failure therapy, supportive psychotherapy, and then you can go for the operations, or the surgical fetus removal. Okay, if the fetus is viable, then definitely you should go for, like if you want early delivery. Okay, in the cardiomyopathies in pregnant women could lead to the death of mother and child both. Okay, remember this, in the fetus cardiomyopathy, sorry, not fetus, like in the peripartum cardiomyopathies, mother and child both have the high risk of sudden death. So in that case, people, I mean, the team of the doctors, if they feel they can go for early, delivery. Early delivery is not premature delivery. They can go for 6 months or 7 months delivery also. Okay, and if everything is good, if the fetus is viable, then they can continue with the pregnancy, or they can, monitor for some more time. This is amyloid related things, like, the toxic cardiomyopathies. So management of restrictive cardiomyopathy and heart failure, management of orthostatic hypotension, management of arrhythmias, stroke prevention, sudden cardiac death prevention, as I told you. Okay, and then these are the symptomatic preventions, or the chronic problems prevention, or the treatment for the underlying causes. Okay, not specific therapy. This is the dilated cardiomyopathy algorithm to treat. If there is a symptomatic dilated cardiomyopathy, definitely start the treatment for heart failure with ACE inhibitors, with beta blockers and all, right? And then if the hemodynamic improves, then continue the treatment and follow up the patient. If the hemodynamics are not improved, then go for biopsy, check for viral infection or any inflammation present. Okay, and then again continue the therapies. Okay, guys, so I hope, I mean, this is quite overwhelming for all of you, but I tried to cover everything. So there are other surgical managements, that what we use in heart failures, like starting with the beta blockers, cardiac resynchronization therapies. And for the surgical treatment means, if the patient is having myocardial infarction, then go for bypass surgery, or kind of devices, stents. If the patient is having valvular heart problems, then you can go for mitral valvuloplasty, or you can go for if the patient is having arrhythmia related problems, you can go for ventricular assisted device, VADs. If there is severe heart failure, you can go for heart transplantation, or there are regenerative therapies also. Okay, so these are the, again, symptomatic and underlying causes problem, complication management, right? Complication management, not exactly the cardiomyopathies management. So you have to treat the underlying causes and the complications if you are treating the cardiomyopathy. So that's all, guys, from my side for the cardiomyopathy. So if you have any questions, please suit up. I hope you liked the classes. It was quite overwhelming. It was quite tough for me too. Also, I also thought 100 times like how to arrange the class, how to arrange the slides. I could make 200 slides also. I could make 15 slides also. But I felt like you should understand the things. It is very, very important for you to understand the basics first. Yes, Anirudh is raising hand.
Sir, please explain about cardiac resynchronization therapy.
Which one?
Resynchronization therapy, cardiac.
Okay, so CRT, cardiac resynchronization therapy, is actually for the heart failure. Again, I'm telling you. So that is when the patient is having SSS, called what we say it, that is sorry, SA node syndrome. In that case, people usually go for the cardiac resynchronization therapies. The major indication for cardiac resynchronization therapy is QRS. The QRS duration, okay, in the ECG must be more than 140 millisecond. Okay, if the patient is having that, because see, more than 140 millisecond QRS means that the heartbeats are irregular, and the duration between the heartbeat, duration between the systole and diastole, okay, systole and diastole, the duration between the systole and diastole means the pumping, okay, duration between the pumping of the blood is quite long. So in that case, the patient can go to, when the patient is not getting the blood to the entire body, and the heart also, because coronary arteries goes to the heart also. I mean, they also supply the blood to the heart also. When the delay, the delay of the blood supply, or delay in the QRS, okay, this delay in the QRS is quite high, QRS duration is quite high, then in that case we need additional support to decrease the decrease the duration, or to increase the pumping capacity of the heart. That's why we keep CRTs. Okay, that's why we keep cardiac resynchronization therapies. Resynchronization means we resynchronize the cardiac rhythm. We resynchronize we give the external support to the heart to pump it well, right? So that is called cardiac resynchronization therapies. You can read it more, but the major impression or major indication for QRS duration, for the CRT, is QRS duration more than 140 milliseconds, right? That means like the duration is quite different. Okay, so someone is written. Okay, so gestation cardiac myopathy, that is peripartum cardiac myopathy actually. Okay, so safe drugs, see, in heart failure in pregnant women, dealing with that is quite tough, but still there are the beta blockers which can be used. So in the pregnancies, so propranolol was there once, and usually they go for the early surgical removal of the fetus. Okay, so cardiomyopathies usually do not have the drugs, usually the treatment of heart failure. Okay, so in the peripartum cardiomyopathies, or the heart failure, we can go for the beta blocker. Okay, specific beta blockers, not the proper beta blocker. Okay, I mean, not all the beta blockers are useful. Okay. Labetalol, I can just see in the Google. Labetalol is the safer beta blocker, which we can give in the pregnancies. Labetalol. Okay, so any other question, guys? YouTube people also can suit up the questions if they have. I'll share the document, by the way, guys, so don't worry. Okay, I'll share the document in the group, so you can just check and you can just learn from that. You can go for that along with the recordings.
Sir, good afternoon. This
Yes,
is Dr. Venkateshan.
Yes.
Yeah. Sir, actually, most of the people try to stay away from the problem before it arises. So, can you say any lifestyle modification or any other suggestions to stay away from that?
Definitely. Just avoid the stress and sedentary lifestyle. I'll say only two things to avoid any kind of cardiac problems, and including cardiomyopathies. Good food is the third thing, but before that, you have to take care of your sedentary lifestyle. Please avoid the sedentary lifestyle. At least 30 minutes walk or 30 minutes cardio is important daily. Okay, I mean 15 to 30 minutes cardio is important daily, right? Or 30 minutes walk you must go. You all must go, whether it is irrespective of any age, I'll say. Okay, if you are adult, elderly, 40s, 50s, 60s, all must go for a walk daily. Okay, so lifestyle modifications and the stress, you should not take much stress of anything, whether it is a work related stress, family related stress. You should try to find out the solutions, but not to just carry forward that baggage, carry forward with that baggage of the stress, because these are the two major problems, or these are the two major causes for any kind of cardiac problems, or the cardiomyopathies. Stress is directly related. Even the cardiomyopathies are named with the stress induced cardiomyopathies. So better you avoid the stress and sedentary lifestyle.
Thank you, sir. And
Thank
one
you.
more.
Yes.
Most of the time, whenever we are facing any type of heart failure, we are going for counter the symptoms.
Yes.
Yeah. What is the real or exact act to counter the problem? Either go with counter the symptoms or the exact problem, because it is not possible to locate the exact problem and counter immediately.
No, see, whenever you are finding the symptoms, see, heart failure symptoms could be due to anemia, could be due to your respiratory problems like asthma or COPD, because these are the major things which can mimic the heart failure symptoms. So better just go for a provisional diagnosis like ECG and echocardiogram. These two things are mandatory. Okay, if you feel like patients can have the heart failure, then do not start the drugs without the echocardiogram. What I'm saying is, see, your fatigue could be due to your anemia, could be due to your other problems. Sleep problems, I mean, these orthopnea or PND, this nocturnal dyspnea, could be due to other problems also. Swelling in the ankle could be due to your kidney problems, or could be due to your sleep problems, could be due to the drugs also, or could be due to the excess alcoholism also. So better first diagnose, because heart failure is not if you have, I mean, if the patient is having the heart failure, not the sudden cardiac death, you cannot do anything, definitely. Okay, but if the patient is developing heart failure, then definitely go for the proper check and then start the medications accordingly, because you even don't know what kind of heart failure it is, whether it is systolic or diastolic, whether it is preserved or reduced. So first, the recommendation is go for the ECG and echo check.
Yes. Thank you very much.
Okay, anyone else, or should
Yes,
we
sir.
wind up, guys? Yes, yes.
Sir, how do you differentiate between hypertrophic cardiomyopathy patient and a athlete's heart?
Okay, hypertrophic cardiomyopathy and athlete's heart. See, athlete heart also has that actually athlete hearts could go for the WVW syndrome. Okay, WPW syndrome, that is called Wolff-Parkinson-Wolff syndrome. Okay, so that could be the overexcitement or overexcitement or pre-excitation of the muscles, of the cardiac muscles. Okay, so that can be easily defined by the checkups, that can be easily defined by by the echocardiogram, that can be easily defined by the ECG also, because WPW can be detected in the ECGs also. Wolff-Parkinson-Wolff syndrome, that is also could be found in the athlete's heart also, right? So that can be easily diagnosed, but with the technical parts like ECG and echo, not by the symptoms and signs. And I mean, the cardiomyopathy patients will be having the symptoms, typical symptoms of heart failure, not the athlete heart. Athlete heart may feel the what we say, bradycardia, the reduced heart rate, that could be there, but there will not be the typical symptoms of heart failure.
Thank you, sir.
Okay, any other question, guys? Okay, so guys, thank you very much, and we'll be sharing the feedback form by evening. You all are welcome to fill the feedback form, and once you fill the feedback form, you all have to watch the videos also, because I can see only 100 or less than 100 people are attending the classes, or maximum 150 out of 800. So I want everyone to go through all the classes, then only the certificates will be provided, right? So thank you guys, thank you very much, and again thank you for joining the series 1, and I welcome all of you to join the series 2 and the entire master's program. Okay, so take care guys, thank you, take care, bye bye.
Thank you, sir.
Thank you.